Good morning, everyone. Thank you very much. It's great to be here at the CADR conference, face to face. I'm going to be talking to you today about a project that's funded by Improvement Cymru that I'm doing with my colleagues here, Joe and Emma. Joe and Emma will be getting up just to explain it a little bit in a moment, but they didn't want to stand here next to me for 10 minutes, just kind of nodding next to me, and I don't really blame them because it would look strange. So yes, so we're looking at language, and we're really interested in language in healthcare. We're interested in language, particularly about people living with dementia. Now, as many of you may be aware, many of you will be clinicians, that part of the daily routine of actually working in hospital is to write clinical case notes. And that's a written account of what that person has been doing during that day. So what we're interested in is, what is that language like? How are people actually being looked at, discussed in those case notes? Because language is powerful, and language has the ability to actually give people power or take it away. So the aims of our project, which will appear if I do this, maybe, no, try that. Ah, there they are. It's to look at language, explore it, and maybe look at how can we improve the use of language about people living with dementia in clinical case notes. We're interested in actually saying, okay, if we can improve the language, can we actually see any changes in care as well? Does that actually impact on the care that is delivered? We've spoken a lot in previous sessions in terms of other conferences, other papers around language that's spoken and the impacts that has. But this is particularly focusing on the language that is written down, because language is generally quite social, isn't it? Language is a social thing. So even though we're writing case notes down, it's actually the case that, other people read those case notes, and it constructs the reality of who that person is. So if our case notes aren't that great, if they're very short and just quite descriptive, that's who the person becomes. So what we're interested in doing then is to develop some language guidelines and saying, okay, what else can you be thinking about rather than just describing someone through their behavior? So yeah, language is something that gets inevitably influenced by other people. All the time, and we hear what you think about, even something like it was mentioned before, the COVID-19 pandemic. The amount of language that was on, it's very hard to control language now with social media and things like that. People were so influenced by what they read, what they heard, and sometimes it didn't matter who said it. It was just what people read that people would go along with it, and that constructed their reality. So we have to think, actually, if these things are being put down in case notes, it could have the impact that it takes away people's rights. It takes away their ability to speak up for themselves. Sorry, wrong thing again. So positioning theory, what is it? So we're looking at language from the aspect of positioning theory. You may have heard of positioning theory before, perhaps not, but it's built on this idea that language has a force. So the locutionary force is just the act of either saying something or writing it down. It's just a physical act of doing it. But the illocutionary force is the meaning that's conveyed by the words. What does it actually tell you about that, what the person wants from saying that thing or writing that thing? So for example, if you've got teenage children, so you've got a 12-year-old son, and you say to your son, well, you go and wash the dishes. Okay, so you've said it. That's what it means. Well, what's the illocutionary force? Well, it means that I want you to wash the dishes. Okay, that's what basically it's telling you, that I don't want to do it. I want you to do it. But the key to positioning theory is then the perlocutionary force. How does your language inspire action? So if you say that to your child, the child might go, oh, I understand. They want me to wash the dishes. I will go and do them. And off they go and do the dishes. And there you go again, well, successful interaction. But actually, a child actually might go, what's in it for me? And the perlocutionary force might them going, well, what do I get out of that? So actually, we start again, and then almost the power is changing. And actually, you might start to go, well, I'll tell you what, I'll give you 50p. So now the perlocutionary force says, oh, if I'm getting 50p out of it, I'll go and do it. And again, the illocutionary force, what you wanted, you get what you wanted. But what your son might say, if they're offering 50p, they might go for £1. So actually, the perlocutory force is now more of a bargaining tool where you can go, okay, well, I want £1. Again, the power relationship is changing. You thought you were in charge going, can you do the dishes? I'm the authority figure. Now it's costing you £5. So actually, the perlocutory force is the power has changed. And that's the thing. Language has the ability to either you get power or it's taken away. And that comes to this theory of what we call malignant positioning. Now, malignant positioning is a theory that was talked about by Stephen Sabat. In the 90s, he started to talk about it. And it's this idea that actually the language that we use for people living with dementia, sometimes they might be positioned by their behavior rather than they are as a person. And what makes it malignant, for example, is that the person with dementia might be characterized as being argumentative. Okay? So you're talking to that person and they say, well, actually, I don't agree with that. I don't want to do that. And they're told, well, you see, you're argumentative. You know, since you've had dementia, you've become argumentative, rather than actually the person's trying to speak up for themselves. The person might even say, well, no, I'm actually just speaking up for myself. You say that, but you have got dementia, haven't you? So it's malignant because the actual speaking up for yourself becomes something that just takes away more power, because it's confirming the first idea of the speaker that actually you're argumentative. So that's what malignant positioning is. It's this idea that actually the more we use it, the more it grows as well. And it becomes something that actually then becomes ingrained. And you tend to see it, again, going back to clinical case notes, that it's part and parcel of, you know, what we've learned. Now, before I was at the university, I spent 18 years as a nurse, a mental health nurse, working in clinical settings. So I know from my own background that when I talk about this kind of language that's used, I'm not turning towards clinicians saying, oh, isn't it terrible that this kind of language is used? Because I've used it all myself. And it's part and parcel of just what we've learned, the way we've been told to do things. And it just takes that moment to actually question it. That say, well, actually, just because we've always done it doesn't make it right. It doesn't make it right to actually describe people in that way. The mechanism that we actually use to look at the language is dementia care mapping. Now, dementia care mapping might be something you've come across before. I'll describe it in a moment, but it's based on the work of Tom Kitwood. And Tom Kitwood said, you know, that the sense of the self is shattered in dementia. And for people who are working with someone with dementia, it's up to them to try and put the pieces back together as best as they can. But if we use negative language, if we just describe people by their behavior, we are not pushing that person back together at all. We're doing the complete opposite. We're ignoring the whole personhood of that individual. So dementia care mapping, it's an observational tool that's rooted in looking at person-centered care. So personhood is regarded as undermined if, you know, people are just seen as, you know, a group of just people living with dementia, all the same. No one's treated as an individual. And Kitwood famously said, you know, there are types of behavior that actually enhance the personhood of an individual with dementia. These things that enhance the person are called positive person work. The things that we do that actually make the person feel, again, like a person, like themselves. But he also said that as clinicians, we'll also engage in things called malignant social psychology or personal detractions. And these are the things that we do where maybe we don't think in that way. And we actually just treat the person, not as an individual, but more as a task, as a job to be done, and not really see the person at all. Again, Kitwood wasn't saying that this makes you bad people by doing this. He wasn't saying that generally we do this because we don't know any better, or we've never asked the question. It's the way that we've been taught. But what he says is that first part of actually getting rid of malignant social psychology is almost admitting that you've done it. You know, because it's easy to look at that list. There's a list of 17 different types of positive work, 17 different types of malignant social psychology. And it's easy to sit there and just go, well, I don't do any of those bad ones. But if you think that, the chances are that you do. And actually, you just haven't got insight. Because I can look at those lists, and I can look at my practice, and I can see my own behavior. And I can see that that's what needs to change. Okay? So it's about, first of all, seeing that. And it's the same as language, you know, that's the same thing actually going, okay, well, accept that actually language does need to change. This colourful flower, some of you may recognise it. This was Kitwood's model of psychological needs. And this is what the the dementia care mapping model is based on. Okay, it's basically based on looking at the enhancing actions and the detracting actions, looking at those 5 needs around the circle there. Now, the one around identity is particularly crucial when it comes to clinical case notes, because if you describe people by their behavior rather than who they are as a person, it's generally their identity that you're attacking. Okay. And this is this act of saying that you are labeling the person. If you're labeling the person by what you write, and you know, when you look at labels and things like clinical case notes, you tend to see, you know, certain types of language, you know, that generally creates stigma, generally makes the person stigma was mentioned just before we even got up on the stage, really, to say the more you use it, it just creates this ongoing stigma. It's used more and more. And the obvious things that you kind of see around these things, my other parts of my presentation have gone. It's all right. I will tell you what they are. So some of the more obvious things that might come up are things like if the person is called a wanderer, you know, if someone described as a wanderer, the wandersome. I've seen that mentioned, the wandersome. It's not even a real word, but you do see it in clinical case notes. People say, so that isn't saying why does someone actually go for that walk? What is someone trying to do? It's just simply saying the person is wandering for no reason. The other one we see are things like just calling someone aggressive. Okay, just calling someone aggressive without any context. Now, we're not arguing that you need to get rid of language. We're not saying that you should remove elements of, you know, the language altogether. What we're saying is that it needs context. And I'll give an example. So, for example, you know, if a gentleman wakes up, he might be on a ward, he might even be under a section of the Mental Health Act, but he wakes up and he's disorientated to time, he's disorientated to place, and he wants to leave because he feels he has to get to work. Okay. So he says, I need to leave, I've got to go to work. And he's told by staff, no, you know, sit down, you're retired, it's not time for you to go to work. He says, no, I really need to go. You've got to let me out. No, you don't need to, you've retired. And this conversation goes on and on, but the person's getting more agitated because for them, their reality is, I need to get to work because if I don't get to work, I'm going to be sacked. I'll get sacked, can't pay my mortgage, my wife might leave me. All these things are going on for that person. And it might be that that actually builds up so the person might become verbally aggressive, possibly even physically aggressive because of that. But if the case note just simply says that Bob or whoever was disorientated and aggressive today, that tells us nothing. All that says is that he is an aggressive man. It doesn't give any context to what's going on for that individual. It doesn't tell us anything that we can do to help that person either. And that's what we're arguing is it's not to say get rid of that language. It's to say, actually, we need context. Some of the other things are less obvious, though. Some of the things that I just think I've written for years and years. We often write people are compliant with medication or non-compliant with medication. And that suggests power straight away, doesn't it? If someone is non-compliant, that sounds almost custodial. When actually the person said, well, they've chosen not to have it that day. They've said they don't want it. They've made that decision. They might have, again, the insight in that decision might be things that you'd look into. But to say they are non-compliant automatically puts the writer in a position of power. Again, if you walk with that person through the ward, wherever it is, and you write, you know, the person, rather than they walked with staff through that ward, you write, and you do see it, that the person was escorted through the ward. Again, it's custodial. It suggests the element of power. The other one, there's one of the things we've said to people, actually, you just need to get rid of it. Because I was saying is in most things we just say, well, you don't have to completely erase language. But you do see it quite often where people would write, no management problem. Okay, that would be the entry for the day, no management problem. See people nodding, going, yeah, I probably wrote that myself. I know I have written that as well in the past. But what does that actually tell you? It tells you nothing about that person. What it actually tells you is, no, the person's not caused me any trouble today. You know, don't know what they did, but actually they didn't bother me. So it's nothing about that. We've kind of said, no, you just need to get rid of that. You can't say that because it has no value. You have to think, okay, what's going on for that individual? So we've given that we've created some language guidance around this, but I'm now going to pass you to Joe Daunt and Emma Roberts to talk to you a little bit about what we're actually doing. Okay, so Joe and Emma.
Thank you. Hi there. My name's Emma, and I work in the dementia care mapping team in Cardiff and Vale University Health Board, and we're currently collaborating with Ian on the study. So the study started in April last year, and it's due to come to an end in June of this year. And as part of our usual roles in the DCM team, what we do is we undertake cultural maps, and that's where we look at the general culture of care on the wards. We do these every 4 months. So in that respect, the study is fitted in quite nicely with our usual work routine. So at 3 observational points over the course of the study, we audit case notes, specifically looking at the enhancing or the detracting language in those notes. And then we carry out a cultural map and feedback both elements to the staff team. So the first one obviously was a baseline audit, and what we did see was quite a high level of detracting language used in those case notes. It ranged between 50 and 65% across the three wards. So then what we did then was we supplied the guidance list of the suggested language to the staff. But I'll just let you, I'll hand over to Jo so that she can let you know more. Thank you.
Thanks, Emma. So I work alongside Emma in the dementia care mapping team. Once we'd had the baseline audit from the wards, and as Emma said, there were really quite high levels of detracting case notes. So language used within there, as Ian has already explained, consisted of labelling. Patients were described as wandering or interfering, confused, disoriented, with no context. So once we'd undertook that baseline, for the second round of audit, we developed a language guidance sheet. So in there was just some examples of detracting and enhancing language, what they meant, and this generated discussions with the ward staff really about what language can be used, what language can't be used. What we wanted to emphasise was we're not saying you cannot use this language. It was said to me, well, we can't just make all the language fluffy. I said, no, it's really not about making language fluffy. We are describing people who have high levels of need in hospital, and that's okay. But what's really important is that we give some context to some of the descriptions that are used in the case notes, and that wasn't happening at that time. It generated lots of discussion, and I must say the ward staff really embraced it. They came to us with lots of questions amongst themselves. They discussed language, why something was detracting, why something was enhancing. So from that perspective, it was a really positive exercise, even halfway through, really. We've done our second round of audits, and you'll be pleased to know, we were pleased to see there was an actual reduction in the amount of detracting language seen in the case notes. It was really quite positive. Difference across the 3 wards because they have different formats in the way they write. One ward used a template, and that sort of lent itself to quite detracting language. So that's a conversation that might come out of this for them to have amongst themselves about, do we actually need to use this template? What we also wanted to do is include stakeholders in the discussions about language. And so we placed 3 suggestion boxes outside the wards that other people can access, families, relatives, and other staff members, and ask them for their suggestions about person-centered language, really. We haven't opened the boxes yet. I'm hoping it's not just full of gloves and masks and used cigarette ends, but we'll see. I'm hoping there's some really positive suggestions in there. So what we aim to do, as well as seeing changes in the language used in case notes, is actually, do we see that come through to the interactions that we see on the ward? Does language actually create reality? So as part of the mapping process where Emma and I observe the wards, we hope to see is whether, when we map, do we see changes in the level of detractions that we see in the interactions between staff and patients? Do we see a change in the enhancing interactions that we see? We haven't analysed that data yet. We will do so by the end of the study, and maybe we can come back next year and share the results with you. And I can also tell you what we found in the boxes, which I think has been the most interesting part. Thank you for listening to the presentation. If you have any questions later, please find us. Thank you.